Hello, this is Dr. Scott MacLean, and today we'll be talking about bone grafting the jump gap. Now, the jump gap is the gap that is ahead of the implant when you do an immediate implant. We'll be using the X guide to do the navigation. So this is a immediate placed situation, so extraction and then placement of the implant using high-tech equipment. This all starts by using DTX Studio for the planning. And once we take an x-ray with my OP3D from Cavo, we're able to put this into a systematic way to plan the implant, then to use X-Guide to place the implant. So it's a really fantastic way to do things. So as this camera system looks over, we can see with the patient we're using high-tech equipment to get this in the exact position, so then we can do our jump gap bone grafting. So it all begins by having the setup done properly. Everything is, of course, sterile, and we're using trackers. You can see the patient tracker on the left, the handpiece tracker on the right. And as I move my hands, I can see it on the screen. So it's almost like you're using GPS to navigate and put this in position. So it's like you're in your car backing up. You can see as you move your hands, this is moving back and forth. So once we get the implant in, we're using a TiUltra surface here. You can see that the idealized placement, we can see the line on the driver telling us that we're actually 3 millimeters below that zenith margin, as I discuss on my implant planning videos, so check those out on the YouTube site. And you can also see how we use the X-Guide a little bit closer and the implants themselves on the site as well. So we can check the torque here, and the torque is about 20 Newton centimeters. So I can't put an immediate temporary crown on for the patient, so temp shell. And so I'm not able to do that. So what I'm going to do instead is to take and make a customized implant healing abutment. By cutting the cylinder down, we can make this abutment so it's not going to have any lateral torque on it. Because the reason why you can't put it on is because you don't want the teeth or the food or the tongue to hit this. So if we put it at tissue level and hold the papilla, and by holding the papilla, this will make the healing very, very nice and allow you to kind of create the body to be the way it was designed. So we want to preserve the papilla. Because one of the things Carl Misch taught me in his course is there's 7 different ways, but preserving it is the best way. And so when we take the tooth out and put the implant in, you need to preserve that so that it doesn't drop back. So the bone grafting and plus the healing abutment, which is customized. So we'll put it in chlorhexidine here and allow it to be kind of rinsed off and washed off. And once we place this on the implant, now the flowable is not getting to the implant at all. And so you can see that as we start to pick up the shape of the soft tissues, then we'll be able to make this so that it's going to really support that papilla and then keep the bone grafting in that osteotomy, because we want that jump gap to be kind of filled in and supported so that the new blood is going to kind of flow in that area, and then the body's then going to take over and start to create new bone. And so we want that area to kind of stay plump and full so that it doesn't look like it's collapsing over time. So we'll add floss to the driver when you're doing it, because we don't want you to have the patient swallow this. I'm doing this for the video. So we'll start to get everything ready, and we'll use a replica. You can see the code here from NobelBiocare for the narrow platform. And when you use the replica, it acts like a handle, so you can really do the delicate work of filling in the area. Now, I don't go in there and polish all this. I want this to be slightly rough, if anything, so that the soft tissues can kind of join on. And when you take this out, you'll see what I mean. There's the replica, of course, and we can see that that is a great handle. I use an 8850 KR diamond to kind of shape it, but to cut the cylinder, I was using a 557 crosscut burr, which is going to create a few sparks, so keep it away from the patient's mouth. Now, it's always important to use the CC bone mill to make sure your healing abutment is going to get down all the way. As you can see here, it's getting bound, and so by using the CC bone mill, we're able to kind of put the guide on and then cut the top of the bone. And actually, I'm proud that I was the one who designed this particular bone mill. Now, we put it in chlorhexidine before we place it back in the mouth. we're going to use a bone mill guide, and we'll take that to the mouth and use this so that the bone will kind of find its way up around the implant rather than into the implant, because I don't want the bone to fill up the implant. So I get this in position. You can see how nicely the implant is positioned, and it's at the right depth, angulation, and so we'll start to do the bone grafting component, which is going to bone graft the jump gap, which is ahead of the implant. Now we're going to be using Creos allograft, and we'll choose a 0.5 to 1 millimeter size of this corticocancelleous bone, and we'll use 0.25 cc's of this. So we're going to mix it with some sterile saline, and we'll take a sterile gauze and just dab it so you take off the excess water, and it just makes it so that it's going to be a nice consistency for placing ahead of the implant. So I'm going to use a bone spoon from salvin.com, and this tool enables me to carry the bone, and then I'll actually use a Molt to kind of scoop it off, and I'll turn the bone spoon over, and it fits nicely ahead of the abutment.
And this allows you to move the bone down the jump gap, and we don't want the bone really above the implant anyway, but you can just kind of push it in there and make sure that that jump gap is kind of full but not overfilled, so that the blood will then come in and form bone in that area. Because we found that over time that this can kind of resorb, and so this helps to prevent the resorption. And so a good little extra step to do. So as we're putting the bone in, you can kind of see that it doesn't take a whole lot of bone in this area. Some people will kind of put the bone in before they put the implant in. This is the way I choose to do it, and so I just don't want the bone going in the implant as we discussed, because then you have a problem when you screw on your healing abutment, which is the next step to do. And so it takes a little bit of time, and then once we get it in there, we'll just take a gauze, sterile gauze, and go in and clean it off. So now we can take the abutment off after leaving it a few minutes, and this lets the bone graft kind of firm up with the blood clot. And then you'll see we can put in our immediate temporary healing abutment that's customized. And this will allow you to keep that papilla kind of supported and on both sides. You can see that it puts a little bit of a blanch on the tissue, and this should go relatively quickly, like within the first couple minutes. If it doesn't, then you need to cut a little bit back off of your abutment. You can see it's already going now. Then we'll take some polyvinyl siloxane, and this is from 3M. You can see we just filled the channel so food doesn't get in there. So this healing abutment allows for it to heal without having a lot of force, because we can't have any force on this. So this has been Dr. Scott MacLean, so enjoy your implants.